Greetings, this is Rob Cipriano, police psychologist at Fort Lauderdale Police Department. I'm going to go over the clinical part today on post-traumatic stress disorder and understanding the unique aspect of it, but also talking about some of the treatment recommendations and resources available. We first want to look at what is anxiety. And when we look at anxiety, we look at three particular areas. We look at anxiety physiologically, behaviorally, and psychologically. Physiologically being it includes body reactions such as rapid heartbeat, muscle tension, queasiness, dry mouth, or sweating. Behavioral reactions such as that it can sabotage one's ability to think, act, express, or cope with certain everyday situations. And then psychologically, the subjective state of what you tell yourself. All right, what I call the thoughts become words, words become actions. It can be a subjective state of apprehension and uneasiness based upon what we tell ourselves each and every day. There's three levels of recovery, and what we look at is we look at trying to reduce physiological reactivity, eliminating avoidance behavior. So it's kind of like a double negative, but eliminating avoidance behavior is basically not avoiding. That's really what that's talking about. And changing the inner dialogue of someone's mind, what we call the subjective interpretations or self-dialogue or self-talk that can certainly continue apprehension and worry. Anxiety can appear in different forms. It can appear in some of these clinical terms: panic disorder, phobias, OCD, also known as obsessive compulsive disorder, acute stress reactions, post-traumatic stress disorder, and generalized anxiety. When we talk about acute stress disorder or acute stress reaction and post-traumatic stress disorder, we're talking about an outside event that can trigger those types of responses. And generally, the outside event is a critical incident. It could be, God forbid, an accident. It could be an injury, something that happens outside the norm. The main difference between the two is they pretty much look the exact same thing with the difference of time frame. Acute stress disorder, the symptoms go away from 30 days and under, and then PTSD generally happens from 30 days and beyond. And I'm going to talk a little bit about that now. When we talk about PTSD, we first have to try to understand the history of the diagnosis. It came out in the late 70s, early 80s. It's classified as an anxiety disorder, and it was first established by the American Psychiatric Association in 1980. That's where it actually came out in this book called the Diagnostic Statistical Manual. But the condition was well established way before, even dating back to certainly Roman times, and certainly fast forwarding to the Civil War and subsequent wars. It's been known as battle fatigue, gross stress reactions, combat fatigue, shell shock syndrome, soldier's heart. Those are some of the terms that it's been referred to over the years in the clusters of symptoms. It involves the fight or flight responses as it relates to dangerous situations or triggers. So you can see a narrowing of vision, muscle tension, sweating, and more sensitive hearing. And these changes are adaptive over time, but they become what we call maladaptive or unhealthy when they start happening in regular situations and in regular settings. It's a hyper state of arousal that can certainly activate that fight or flight response, but there's also a freeze response as well. And then you can have experiences such as flashbacks and intrusive memories, which I'm going to refer to in a few minutes. We want to look at the first criterion, what we call criterion A. The person was exposed to the event. Could be a death, a threatened death, actual or threatened serious injury, or actual or threatened sexual violence in the following ways, such as direct exposure, witnessing the trauma, learning that a relative or close friend was exposed to the trauma, and any type of indirect exposure to aversive details of the trauma, usually in the course of professional duties, and that includes first responders. Criterion B, the traumatic event is persistently re-experienced in the following ways: nightmares, flashbacks, emotional distress, physical reactivity after exposure, and certainly upsetting memories. Criterion C, avoidance of trauma related, and the avoidance can be, I'm just avoiding whatever that activating or triggering event is, whether it's a situation involving a location, a circumstance, an individual, trauma-related thoughts or feelings, and certainly reminders that take you back to the trauma, such as dates, anniversaries, things of that nature. Negative thoughts and feelings that began or worsened after the trauma in the following ways: inability to recall key features of the trauma, overly negative thoughts and assumptions about oneself or their world, exaggerated blame of self or others, negative affect, decreased interest in activities, and feeling isolated and difficulty experiencing positive emotions and affect. Criterion E, and again, at the very top of each slide, I give you the minimum. So in this one, 2 are required. For this particular category, trauma-related arousal, irritability or aggression, risky or destructive behavior, hypervigilance or hypersensitivity to one's surroundings, heightened startle reaction, difficulty concentrating, and certainly challenges with sleep. Criterion F requires symptoms that last for more than 1 month. Criterion G, symptoms that create distress or functional impairment, whether it's socially, occupationally, or legally. And criterion H, symptoms are not due to any medication, substance usage, or abuse, or other illnesses. What we look at specifically with post-trauma, and I will refer to it as the difference between traits and a full-fledged disorder. There can be a number of people that have traits, and there can be a number of people, or a short particular domain of people that actually have the full-fledged disorder and have problems in 3 areas: socially, occupationally, or legally. What we also look at that's not on the slide is how intense, how frequent, and how long those symptoms occur. So like I mentioned earlier, you want to look at PTSD as beyond 30 days. It certainly can start as an acute stress disorder within 30 days, but then now trickle into and evolve into beyond the 30 days. And that's generally when someone needs some attention, when those symptoms continue and or intensify that I just covered. Want to go back to the FLPD SOP. City procedures still apply, and workman's comp injury form is needed once symptoms present themselves and treatment is needed. Stigma is also a factor that we have to deal with, which is generally what I call the poisonous seed that can fuel the condition. And it's generally a perception. A lot of times for us within the law enforcement community, it's not seeking help for fear of being ridiculed or judged and involving mistrust. For PTSD to be considered a clinical condition, like I mentioned, it has to be those 3 areas, either of them, socially, occupationally, or legally, and the condition can wax or wane over time with other stressors, and it can also be accumulative. Some of the things that I'm offering with the Psychological Services Program, which I include my phone numbers there, but the types of therapy that treat PTSD are EMDR, which stands for eye movement desensitization and reprocessing, and cognitive behavioral treatment. Both of those treatments are performed specifically at Psychological Services Program. We also have our peer support team and our peer support team supervisor, which is Captain Lynette Falzone. And then we also have our EAP through Cigna with the phone number listed. Once again, I thank you for your service, your dedication, and commitment. And I'm wishing you a very, very successful career. Thank you.